Mr. Mitchell, Excellencies, Heads of State and Government, the First Lady of Burkina Faso, Madam Melinda Gates, our brother Babatunde of the UNFPA, distinguished delegates, ladies and gentlemen, I sincerely thank Prime Minister David Cameron and Madam Melinda Gates for associating me with this important summit on family planning. I commend Her Majesty's government and the Bill and Melinda Gates Foundation for conceiving the idea of convening the summit and for organizing it so well. I also like to acknowledge the UNFPA and other partners for supporting the preparations of this summit. Improving the health of women and children is a major policy objective of the government of Tanzania. As a result, a number of measures have been put in place and interventions made in this regard. We've been compelled to do so because we are faced with maternal and child mortality rates that are quite high. Maternal mortality is 454 per 100,000 live birth, and under 5 mortality rate is 51 per 1,000 live birth. Excellencies, we have adopted two-pronged approaches in efforts to tackle the twin challenges. First, we have dedicated our efforts and a substantial proportion of our budgetary resources towards improving antenatal and postnatal care to pregnant women in order to make pregnancy safe for Tanzanian women. In the same vein, we have been taking measures to improve availability of requisite services to children under 5 so as to ensure their survival and give them the chance to grow into healthy and productive adults. Secondly, we have been promoting family planning as part of the National Reproductive Health Strategy. Among the important benefits of family planning is the fact that 20 to 35% of maternal death could be avoided through prevention of unplanned and unwanted pregnancies. Also, mothers and children can become healthier, and families can better provide for the care and upbringing of their children. Girls will not be forced to drop out of school because of unexpected pregnancies. It is good for the overall growth and development of the country. Family planning has a long history in Tanzania. It dates back to 1959, when family planning services were first introduced by the International Planned Parenthood Federation. The IPPF worked through the local family planning association affiliated to it, famous in Kiswahili as UMATI, Chama cha Uzazi na Malezi Bora. In 1974, the Family Planning Association in Tanzania was allowed to use maternal and child health clinics of government throughout the country for delivery of its services. But in 1989, there was a major policy shift of government when it was acknowledged and underscored that family planning is important for national development. As a result, the first national planning program, family planning program, was launched. In the new policy development, the significance of direct government involvement in family planning matters was underlined. From then on, government assumed responsibility over family planning services instead of leaving it entirely in the hands of the UMATI. Family planning services thus became an integral part of maternal and child health services in the country. In 1993, the government launched the Green Star campaign. The objective of the campaign was to increase awareness of family planning among the people of Tanzania and bolster the implementation of the National Family Planning Program. When we came to office in 2005, we made improving health care for the people of Tanzania a major development agenda of our government. In that agenda, reducing maternal and child health was given top priority, hence the national roadmap to accelerate reduction of maternal, newborn, and child death, the 2008-2015 program. In the roadmap, family planning has been recognized as a critical component for two reasons. One, inadequate birth spacing and multiple pregnancies put women at risk, while unintended pregnancies lead to safe abortions. Both of them cause death. When we look back through the tunnel of history of family planning Tanzania since 1959 to date, we realize that some progress has been made. When the government assumed responsibility for family planning in 1989, Umati had already succeeded to raise contraceptive prevalence coverage to 5% from nothing. Efforts deployed thereafter have enabled the prevalence rate to reach 27.4% by 2010. This is far too low, but we are committed and determined to do better in the coming years. We have set ourselves a target of getting 60% contraceptive prevalence coverage by 2015. This means increasing the number of women under contraceptives from 2.4 million in 2010 to 6.6 million in 2015. This goal may look too ambitious, but I'm confident that it is doable. Two things give me the confidence to say that. First, that women who need contraceptives are many, and we have not met their needs yet. The unmet needs stand at a high 25%. Secondly, fertility is still very high at 5.4% in 2010, which indicates that the opportunity of scaling up exists. What is required of us is to ensure that the National Family Planning Costed Implementation Program is implemented fully. Its strategic areas include ensuring contraceptive security, capacity building, advocacy and demand creation, service delivery systems, as well as management, monitoring, and evaluation. It has been estimated that $88.2 million will be required between 2010 and 2015 to meet the contraceptive commodities and supply costs. Fortunately, we in government already have a family planning budget line for commodities. It is also benefiting from the contribution of health basket partners like the USAID, DFID, the Australia Aid. We therefore look forward with great anticipation to the outcome of this summit. We would like to see the financing gap closed so that we can provide the targeted 4.2 million women with the contraceptives they need, but also they deserve. Allow me to use this opportunity, before I conclude, to express my deepest gratitude to all our development partners, both state and non-state actors, for the generous support extended to us on family planning matters over the many years. It has made a huge difference, and it accounts for the achievements made so far. Modest as they may appear, but we would be worse off today without that support. Let me give one example to illustrate what I'm saying. Between 1994 and 2001, DFID funded the Mbeya Family Health Project, which helped increase the demand for and availability of contraceptives to women. At the start of the project, the region had the contraceptive prevalence coverage of 8%. In 2010, prevalence rate had increased to 37%. Thanks to DFID, the prevalence is now 10% above the national average. Ladies and gentlemen, in summary, the main challenges facing family planning in Tanzania are: one, lack of adequate resources to meet the requirements of contraceptive commodities, equipment, and supplies. Two, social inhibitions, including religious and cultural, which can be overcome through education and sensitization. 3, unmet needs of modern contraceptives for young girls and adolescents, which contributes to high fertility rates, unintended pregnancies, and complications at birth. Indeed, through working together, what we have been doing has proved beneficial and successful. Let us continue to work together now and in future to overcome the major challenges of family planning in my country and other developing countries. Together, we can provide the largest population of young people with the choices they need to shape a bright future for themselves, their families, their communities, and their countries. I know we can make such a difference. Let's do it and save many innocent lives. Thank you for your kind attention.